cranial nerves 9 and 10. For 9 and 10, you usually think of them somewhat together. You can ask the patient to say something to make sure that they don't sound hoarse. But classically, what we'll do is we'll have them open their mouth real wide, look for and say ah, look for uvular deviation, tonsillar pillar asymmetry, and then take a little applicator, which looks like a really long Q-tip swab, and they'll be in the rooms, and they'll be laid out for you. And you want to touch the right side of the back of the throat, and then the left side of the back of the throat, and see if they gag. Okay? The patient may tell you further into the evening, it's okay, I'll assume that you've done both sides. Or you might walk up to the patient and say, do you want me to do both sides? But mention both, okay? Because you want to make sure you touch them on the right and on the left. So that's cranial nerves basically 9 and 10. For cranial nerves 11, you're going to have the patient turn their head to the right and resist me. Turn your head to the left and resist me. Okay, look straight ahead, shrug your shoulders up. Don't let me push down. And that's going to be cranial nerve 11. For cranial nerve 12, you're going to have the patient open their mouth really wide. Stick your tongue out like you're going to touch the tip of my finger here. Very good, and that's cranial nerve 12. That would be a complete screening cranial nerve examination. We never taught you or asked you, even in the Friday integrated case practice for cranial nerves, how to document cranial nerve abnormalities. So I wouldn't worry about documentation, but I would remember that you need to know the 12 cranial nerves and make sure that you do them, and I would encourage you to do them in order. Amy?
In the handout, I think it said something about swallowing.
Oh, I didn't ask him to swallow. You could have him swallow too, as a one. I apologize for that. Very good. The last component that we asked you to remember how to do is sensory testing, okay? Ryan?
Just real quick on visual field, do we have to do the contemplation?
Ryan is asking, do you need to do testing like this? Tell me which side I'm wiggling on, or here, or when can you first see it? I personally don't like that type of a test for several reasons. If he has a non-dominant hemisphere, like parietal lobe cortex lesion, and I do something like this, he may not attend to his left side even though his vision is absolutely fine. And so I think that that's a little bit of a dirty test because you can assume that someone has a visual field defect solely from neglect. And you would not find that if you checked each individual eye separately. So I would prefer that you not do something like this, which side do you see wiggling? Although you could do that if you're looking for neglect. I think that's more of a cortically based way of looking for visual neglect as opposed to really looking for a visual field defect. Does that make sense?
Yeah, if you can just say, do you see my, I kind of spaced for a second right when you're doing that.
This is how I would check peripheral vision. Look into my eye. Can you see my whole face?
Yes.
Is any part of it missing?
Nope.
How many fingers?
2, 1, 1, 2, 2, 1.
I checked all 4 quadrants right there.
Right.
It's really fast. Really fast. And be discreet and check in each quadrant because your grader is going to look to make sure that you've looked in every quadrant. Okay? Very good. The last part is the sensory examination. If you are asked to do a sensory examination on a patient, I will assume that you will start with the lower extremities and that you only need to do the lower extremities. I will not ask you to do a sensory examination of the upper extremities. Although if your patient was only complaining of hand numbness, for example, maybe you would check upper extremities too. But for purposes of the OSCE, if you were asked to do sensory, it's in the lower extremities. So, Bryce, I'm going to have you just scoot all the way back here so your legs are straight forward. You keep sitting up though. Okay. So I didn't bring sensory testing with me, or sensory things other than this tuning fork with me, but there's 5 sensory modalities that you must remember to check. You must check left versus right. And so the easiest to do is initially proprioception. So take the second toe and pull all toes to the side. Hold the great toe laterally or from the sides and tell the patient, this is down, this is up. When your eyes are closed, I'm either going to move it down or up. Can you tell the difference between down or up? Good, close your eyes. And tell me, where's your big toe right now?
Down.
Where's your big toe right now?
Up.
Where's it now?
Up.
Where's it now?
Down.
Where's it now?
Up.
5 times is about fine. Go to the other side, pull the toes aside. Why do you pull them aside? Because if I am brushing by his toes, that's giving different sensory input. This is down, this is up. Close your eyes. Can you tell the difference between down and up?
Yep.
Where's your toe right now?
Down.
Where's it now?
Up.
Where's it now?
Up.
Where's it now?
Down.
Now.
Down.
Good. If you test proprioception like this, you will miss the point. Okay, because that's just checking for pressure, and that's different. It's taking a different pathway. Next, what I could do is check the DCML in the second way, which is with vibration. I always like to tell or verify that patients can appreciate vibration by striking the tuning fork and putting it on their head and say, can you feel that's vibration?
Yep.
Good. Now, you will not be wrong if you go straight to the great toe, to the distalmost joint right over here, which is where you put it and ask them if they can feel it. But what I usually do is I say, can you feel vibration here?
Yes.
Can you feel it at the medial malleolus?
Yes.
Can you feel it here?
Yes.
Can you feel it right here?
Yes.
Good. The vibration is going to peter out. Tell me when it's absolutely 100% gone.
Okay.
Good. Can you feel vibration here?
Yes.
Can you feel it here?
Yes.
Can you feel it here?
Yes.
Can you feel it here?
Yep.
Tell me when vibration is absolutely 100% gone.
Okay.
I want to see if his vibratory threshold is equal. Does the vibration on the right feel like the vibration on the left?
Yes.
Good. So I've got vibration done. I just wanted to make sure he could feel it. I worked from normal to where it could theoretically be abnormal, but it was normal, and I compared right to left. Okay, so I did both extremities. So that's probe, and that's vibe, and that took the DCML upstairs. And so I checked that pathway right now. Now, light touch technically takes both pathways, and so I personally tend to do light touch next. And so I could give you a 10-gram microfilament, which looks like a piece of fishing wire, and that would be set up out on the desk also for you. And you could show the patient and say, this is a piece of plastic fishing wire, touch your face with it, can you feel that little pressure there? Yes. And then you have the patient close their eyes and tell me, and say the word yes every time you feel me touch you. And then what you do is you take the piece of plastic fishing wire and you touch the bottom of their foot until it just flexes a little bit. And they should say the word yes every time that you touch them. It is true that there are different spots on the lower extremity that you need to touch for a diabetic screen. We're not doing this for a diabetic screen, we're just making sure that they can feel light touch. And so as long as you're checking the plantar aspect of their feet and then working your way proximally, if they feel all areas of light touch on the plantar aspect of each foot, then I wouldn't go on. I think that you're fine to have screened for the lower extremities simply with that. So that's light touch, and that takes it both pathways. Now there's two other sensory modalities that we have not talked about. One is temperature. And so with temperature, you know, you'll all have a tuning fork in the room. And so the tuning fork is always cold. So when you're sitting there talking to the patient, don't hold it by this because you're going to want your tuning fork to be cool, okay? And so what I usually ask the patient to do now is, could you close your eyes? I'm going to touch you with something warm versus something cool versus something warm. Can you tell the difference between cool and warm?
Yes.
Can you tell the difference between cool and warm?
Yes.
Good. Tell me, which is cooler, side A or side B?
A.
Which one's cooler, side A or side B?
B.
And I could do that a couple times on the right and on the left, and I will have successfully screened for temperature. The last sensory modality that we have not talked about is pinprick. So in the room, there will be a bunch of little paper sleeves that have within them applicators. They look like a really long Q-tip this big with a wooden stick. I break the stick, and whenever you break the stick, it always leaves a pointy side. And I didn't bring one with me, and I apologize, but one side has the Q-tip swab on it, and the other doesn't. The other is a pointy stick. And so I break it in front of the patient, like, do you see this here? One side of it's soft like the Q-tip, the other side is sharp. Can you feel the difference between the soft and the sharp? Yep, okay. You need to close your eyes. Tell me, which side is going to be sharper, side A or side B? And then they tell you, side A or side B? Side A or side B? Check it a couple times distally on one foot. Then you go to the other side. Which is sharper, side A or B? Which is sharper, side A or B? And you vary it. So one time A might be sharper, another time B might be sharper, whatever. And you just check them a few times here and a few times here, enough so that you feel that you've successfully ruled out a sensory problem in the lower extremities. When I do sensory testing for temperature and for pinprick, I tend to like to do something on the outside of the foot and the inside of the foot. But as long as you're checking both lower extremities. And once they're both normal, then you're done and you've checked all the sensory modalities that you need to check. Light touch, pinprick, proprioception, vibration, and temperature. You have a lot of time to do this. I've never asked you guys specifically to document sensation. That's something that you'll really learn how to do next year. But I do expect that you will know how to check all 5 sensory modalities. So You've got 10 minutes to do it, practice it. If you don't practice it on someone, you're gonna fumble around with the words and you're going to realize that like the motor examination or cranial nerves are gonna take a heck of a lot longer than you think if you haven't really thought about what words you're gonna use. Because it's true, you may have one of my residents as your patient and they'll know exactly what to do. And you may have a standardized patient who's never done this before and has no idea what you want them to do. And so you'll notice that tricks of the trade usually are showing the patient what you want them to do. Seventh nerve is always one of the hardest. Look up to the ceiling like you're looking up. Because if you have a patient